Thank you. I wasn't prepared to really walk around because I don't wear heels that often. And so I'm going to kind of stand, walk as I can. I just don't want to trip and twist my ankle. After having kids, I just don't even try wearing heels anymore. Anyway, thank you for the introduction. So there's a lot we could go over in regards to ADHD and updates. There really hasn't been changes in diagnosis, but there has been an increase in awareness, medication usage, and now drug shortages, which you probably have heard about or are aware of. So those are all going to be things that we are going to cover today. And then, like Jim said, if you have any questions, please save those to the end and I'll try to answer those as best I can. If I can't, then I'll follow up with you. So this message from the DEA and FDA just came out last month because they are feeling a lot of pressure from medicine, so physicians, pharmacy, as well as parents and people living with ADHD is why can I not get my medications anymore? And their joint message was pretty vague, but it's just saying that we have seen an increase in stimulant usage over the last 10 years, but especially during the COVID-19 pandemic. There's been at least a 10% increase in some of the different age demographics. And I'll talk about that kind of at the end, but we've seen a shift in how prescribing has happened, but also diagnosis and kind of self-awareness and what people are talking about on social media, and then going into caregivers to get the diagnosis of ADHD. This is the most recent prevalence data for school-age children. So that first one is all from ages 3 to 17, and you see an increase in prevalence with each age range. So the 3 to 5 being preschool, then school age up to adolescence. And there are some differences that you're probably familiar with. So boys are more likely to be diagnosed with ADHD. That might be because their presentation is easier to spot during that school age year. They're more likely to have the hyperactive the traits versus girls having more of the inattentive traits. So sometimes that gets unnoticed. Our Black and non-Hispanic are more likely to have a diagnosis than our white, non-Hispanic, Hispanic, or Asian students. And then if you look at some of the income and health insurance demographics, this just kind of shows the spread based on where they are falling under the federal poverty line, as well as if they have public or private insurance. So there are differences seen throughout our students. This is older data, but is interesting. So in 2011, Kentucky had the highest rate of children diagnosed with ADHD in the entire country. And so if you see, we're right here in the darkest spot. There hasn't been anything that I've seen more recently, but we're at the 14.8% with a current diagnosis, 18.7% ever having a diagnosis of ADHD. And as you're aware, oftentimes the diagnosis of ADHD doesn't go away. It continues into adulthood. And so this number is probably going to be pretty consistent and maybe even higher at this point. The presentation, so as I mentioned, we go based on the Diagnostic and Statistical Manual Diagnosis. That's what psychiatrists use, as well as our psychologists use for the diagnosis of ADHD. And there are three types. So there's the predominantly inattentive type. So they're forgetfulness, not paying attention, often look like they're daydreaming. So that's more common in girls, especially at the younger age. And then hyperactivity or impulsivity. So we know kids don't have that completely functioning prefrontal cortex yet. So their executive function is low, but they may be squirming, getting out of their seats, blurting out answers, fidgeting. And so that's another type of ADHD. And then there's a combined type as well, where you can have symptoms of both. And so they would meet the diagnostic criteria of having both inattentive and hyperactive. So even in the diagnosis of ADHD for adults, the symptoms need to have occurred before the age of 12. So you may have heard of adult onset ADHD. I work with our adult ADHD clinic at UK Healthcare, and they're still going to go back and look at your history during your school age. They're going to try and get history of how you did in school, what it was like for you. Did you have any special needs while in school? And so going back to this age before 12, having onset of symptoms, and then having the symptoms for a minimum of 6 months. And then you all are probably actively involved with this, communicating with the families or with their healthcare providers, that the diagnosis needs to occur in two different settings too. So it's not just happening at home. I have school age children as well, and so they act very differently at home than they do at school. So making sure that the symptoms are happening in different settings as well, and that's where the information coming from you all is very helpful. And you might be filling out surveys or sheets for the psychologist to help with that diagnosis. The clinical course shifts as individuals age. So with the younger kids, it's predominantly hyperactive impulsivity, tendency for temper tantrums. And this is above and beyond what is normal for this age group, because these are normal behaviors for a 4 or 5-year-old. And so if it's impacting activities of daily living, being able to get out the door, do things, then that's when we would want to consider getting assessment for this. For school age kids, so the 6 to 11-year-old range, it's primarily hyperactive or impulsivity. You may have that inattentiveness, especially in girls, as I've mentioned. And then potentially the oppositional or social aggression could happen at this time as well. And then as they get into adolescence, the hyperactivity, impulsivity it's still present, but it's not going to be the predominant symptom. The inattentiveness is what we start worrying about, especially when they start driving or when they start going to work, because that's when accidents happen, or that's when risky behaviors can happen, such as substance use, which is at a higher rate with individuals who have ADHD. And then with adults, the inattentiveness is what continues to happen. So this is what's going to be not being able to get projects done at work, that safety risk when driving home from work or getting to work and paying attention. So being aware of that this is 60% of individuals who have a diagnosis of ADHD as a child are going to continue to have symptoms as an adult. So for a while, it was only seen as a childhood disease or disorder, and now we're seeing it as a chronic disorder for individuals and treating it as such. So using medications or therapy for extended duration. And then ADHD often doesn't present on its own. There's a lot of comorbidities that can happen with it, most of them being other psychiatric disorders. So there can be other neurodevelopmental disorders. So things like autism spectrum disorder or oppositional defiant or conduct disorders, learning disabilities often coincide with ADHD diagnoses, as well as tic and Tourette syndrome, but also anxiety and depression. So making sure that that diagnosis is also being assessed, because they can oftentimes overlap. They can oftentimes be treated simultaneously, and sometimes we need to treat the more severe one before we can start tackling the other one. So if the anxiety or depression is very severe, then we probably need to target those symptoms before we start bringing in medications or therapies for ADHD. But now we're able to provide comprehensive plans where we can target all of those things at once. And I work in a substance use disorder clinic as well, and we're going to be targeting treatment of their substance use disorder while also treating their ADHD too. And so sometimes that gets really complicated by giving them controlled substances as stimulants for their ADHD, but also treating their substance use disorder as well with things like Suboxone or buprenorphine. So it's a lot of monitoring, but things that we need to consider as well. You should not even be able to read this slide. This is just to show you how many medications when it started, these medications, and how it's continued to grow and grow. So the one that we don't see a benzodrine used. That was the first one in 1937, but Ritalin, methylphenidate, came out in 1955, and it's still one of our mainstay medications for ADHD. And then each year, it seems like a new medication comes out. Even if it's the same active ingredient, it's a different dosage form. So my board certification, I have to remember these for my certification each time, but I still have to look them up every single time because the release rates is different with each of them, how long they're going to last, if they can be crushed or chewed or sprinkled is going to be different for each of them. So those are things that you can also get from the package insert. And I just got asked by a psychiatrist yesterday about the ability to crush one of the medications because they don't know as well. So it's just looking at that package insert and understanding how these different formulations are released, because a lot of them are an extended release formulation, which is beneficial. And this shows the rates of medication use. So for the 4 to 5-year-old, I'll show you what the guidelines recommend. And for 4 to 5-year-olds, behavioral therapy is what's going to be the primary recommendation. So we are seeing that being the primary estimate of therapy for them, but a lot of them are still not getting any treatment. So that purple top bar is going to show you the number of, or the percentage of individuals not receiving treatment. And then we do start using medications, primarily methylphenidates recommended for those younger age groups, but we do start as they're getting older, starting to see an increase in medication treatment, being that green bar, or sorry, that blue bar underneath. The green one being ideal, being therapy and medication, because the combination of the two can be very beneficial, but that can be very challenging because we don't have enough providers out there to be providing these services. Getting a psychologist who specializes in the different, like the reward type of therapy that is needed for ADHD is very hard. Just our clinic alone is going out into 2024 to be able to do assessment and diagnoses for ADHD for our adult clinic. And so it's very challenging to get the services that are necessary, which is why a lot of people are turning to these online resources that you may have heard about, which is where the surge in stimulant medication use has happened. So just to review the medications classes, I've used the term stimulant medications, but we also have non-stimulant options for ADHD. So our stimulant medications are typically lumped into 2 classes. We have the amphetamines, which you probably heard of Adderall. That's usually like the grandfather of amphetamines. And then methylphenidate, which is Ritalin. And then from those different ones, we have branches of different enantiomers or different formulations of those different stimulants. And then for non-stimulants, we do use antidepressants. We use alpha-2 agonists, so those are things like guanfacine, clonidine, you may be familiar with. And then we have the selective norepinephrine reuptake inhibitors like Strattera, so atomoxetine. And then we have a newer one out there that's called Qelbree. It's viloxazine. So I'll go over all of these and just briefly talk about the mechanisms and kind of what to anticipate with them and how you might monitor them in practice. This is the most recent treatment guidelines from the American Academy of Pediatrics. So as I mentioned, for the younger age group preschoolers, behavioral therapy is what's recommended. Not always possible, not always convenient. So medication options being what's next. And then for school age, either using an amphetamine product or a methylphenidate product is the first line recommendation. There isn't a preference. There's not one that's going to always be better than another. So it's going specifically to what would be best for that individual, what would be most convenient for them, what they've tried before. Is there someone in their family who's taking one of these medications that's had benefit or adverse effects? And then if they try one of them and it fails, then trying the other kind. And sometimes we're trying multiple different formulations, different enantiomers. So we have methylphenidate and then we have dexmethylphenidate. So we might try a more specific one if they're having side effects to one. But also looking at things that I look at as like pharmacokinetics and pharmacodynamics. So how long these drugs last in the body, how our body's metabolizing them, the unique release mechanisms of some of these medications. So how they come out and how long they last before we see another peak in concentration. But that gets really complicated and is beyond the scope of this presentation. These are just the newer medications that have come out since 2018. So one unique one is Jornay PM. It's actually one that you give at bedtime, because most of these are given in the morning because a side effect of them can be insomnia, as stimulants are trying to they can cause wakefulness for an individual who has ADHD. We're using them for the benefit of the norepinephrine and dopamine, but that's also going to cause insomnia. So this one was unique in that it's given at bedtime, but because if it's a release mechanism, it doesn't start working until early morning time. And so it's good for individuals who have very early morning symptoms. And so we've seen this used a few times. And then there's some different, like methylphenidate, multi-layered release. So it's just using the same drugs, but just using different formulations to either have like a bimodal release, so releasing in the morning and then again in the afternoon, or sometimes even a trimodal release, so a morning, lunchtime, early evening release, so that we're getting symptom coverage throughout the entire day. The other unique one being the viloxazine, which is Qelbree, which I mentioned, which is the first non-stimulant medication that's come out on the market in many years. And so this one's beneficial because it's for individuals who don't want to have that stimulant medication. Maybe it's not safe for them to have the stimulant medication. And it also might work faster than our atomoxetine, which can sometimes take 6 to 8 weeks to start working, similar to antidepressants. And then there's a new transdermal patch that's out there. So you may be familiar with Daytrana, which is a methylphenidate patch that some students may have. But this new one is a dextroamphetamine. So it's the first amphetamine product that is available through a transdermal system. And that's really helpful for individuals who can't swallow these large capsules. Maybe it's inconvenient to open them up. And so that's a good option for them as well, and decrease side effects. All right, so I mentioned our stimulant classes, they increase norepinephrine and dopamine, and that's going to help with concentration, hyperactivity, as well as control emotional outbursts. So it's going to help with that executive function, maybe help them pause and think before doing the next step. There are short-acting formulations and long-acting. I think the ones that you may interact with most are the short-acting ones, because those are the ones that they're probably going to need to take during the school day. So the perks of having a long-acting medication is it's typically taken once a day in the morning, and then it lasts 8 to 12 hours. So hopefully that's through the whole school day. However, that can lead to longer side effects, because as long as the drug is there, the side effects can still happen. And there is a lower abuse potential with those longer acting medications, but not everyone can take those, or they may have still symptoms that emerge, or they're wearing off sooner than that 8 to 12 hour and they need a short acting medication, or they take the short acting medication multiple times throughout the day. And so those shorter acting ones are faster onset. Unfortunately, they're taken multiple times a day, and there's more side effects, but they're for a shorter period of time because their duration is shorter for the medication. So especially for someone who has trouble with appetite, because appetite reduction can happen with these medications, then taking a short-acting medication might be beneficial, because it allows the drug to wear off before they could take it. They have breakfast, they take the medication, they get an increase in concentration. By the time lunch happens, it's worn off. They can eat some lunch, take the next dose, and then it'll wear off by dinner time. So you do see these sometimes used multiple times a day in children, although not convenient, and can make it challenging when going to school and having to take the medication. These are just examples. I've already mentioned most of them. The other one you're probably familiar with is Vyvanse. So it's an amphetamine derivative. It's actually a prodrug of amphetamine, and so it has to be metabolized. So it has to be ingested and metabolized before it can be activated. And so this one's commonly used because it has less abuse risk associated with it. Unfortunately, it's one of ours that is on back order right now. So it's challenging for individuals to get the higher doses of this medication because of drug shortages, but it is a commonly used medication, and usually just one that you're going to take once a day in the morning. And this I kind of mentioned with talking about Jornay, when selecting these medications and adjusting these medications, and things that you all can help with is, when are you hearing or when are you seeing these symptoms primarily come up? And is there maybe a shift in these medications that we need to make to cover symptoms better, depending on what time of day that they're showing up? So if they're showing up in the morning, making sure that we're getting that quick release and getting that morning coverage to help get them out the door, get them on the school bus, get them ready for school. And versus, are they having middle of the day challenges? And so do we need to make sure that they're having a medication that also releases earlier in like late morning so that they're having coverage? Or is it an after school issue, like they can't participate in sports, which are so beneficial for these individuals? Or can they not do their homework? And so making sure that we have afternoon coverage, where we play with these medications to just kind of toggle what dosage form and duration of activity would be best for that person. This is also going to be kind of similar, but different when it comes to time and type of adverse effects that they're having. We might have to make adjustments based on whether that they're having insomnia, whether they're having mood swings, whether they're having lack of appetite. So it's primarily the amphetamine products that have this box warning, but things that we want to also consider because they can all cause tachycardia or increased blood pressure as well. So segueing right into the side effects, decreased appetite, weight loss can happen where you might even hear about misuse or abuse of these medications for those reasons. Insomnia, headache is common, especially early in treatment, upset stomach, anxiety. So increasing norepinephrine, dopamine can cause some anxiety, some fidgetiness. So seeing if it's difficult to ascertain, but is it the ADHD or is this a side effect of the medication, and getting a course timeline? Mood lability, so it can cause, especially using the shorter acting ones where the drug levels are peaking and dropping quickly, can cause some mood lability. One thing that isn't listed on here is the stunted growth that was talked about for so long. And what's been found is that it's very, very minimal, like maybe a quarter of an inch total lifetime change. And so it's not recommended to do drug holidays or medication holidays if we don't need to for that reason specifically. Sometimes doing drug holidays can be beneficial, though, too, if they don't need the medication over the summer or on the weekend, or to help with some of these drug shortages that are happening. And then less common, but maybe more severe side effects. So it can worsen tic and Tourette syndrome. So as I mentioned, this is a comorbidity, ADHD and tic disorder. So monitoring for symptoms of that, and it's usually us finding a good balance between the stimulant medication and a medication for their tic disorder. But sometimes we need to switch them to a non-stimulant medication. And an increase in blood pressure, pulse. It's very severely more likely in an overdose or misuse would be psychosis or hallucinations with these medications. And stunted growth, I do have at the very bottom, so a less common one, but one that I think I remember hearing when I was younger as a side effect of these medications. And this was probably a good one for you all to, when I was looking at the literature for nurses specifically, school nurses specifically, on things that you all can do to help with management and monitoring of these. So checking in on the appetite, seeing if there is any changes that are happening, ensuring that they're trying to get a good meal in at some point of the day. Ideally, we're trying to get a good breakfast in, a big dinner in, even if the lunch isn't as large, because it's going to be an average over time. It doesn't have to be, every single meal, but an average over time to make sure they're getting the caloric intake that they need. Monitoring for tachycardia, blood pressure changes. That might just be a drug change that we need to do. Assessing sleep. How are you sleeping? If they're dozing off in class, if we're hearing about that, and something that we can talk about with the family, like what is sleep hygiene like? Are they on their phone all night, or they have their phone in their bed with them? And so making sure sleep hygiene is good, but is the time of day of these medications being taken also contributing to that? As I mentioned, worsening tics, Abdominal pain may just require a medication change, same with headaches. And the mood changes, if you're hearing mood changes, if there's more fighting, more arguing, if you're hearing from teachers that they're not acting the same as they used to, then that could be something to also consider with these medications. Briefly, the non-stimulant medications, so they are overall less effective than our stimulant medications. However, there are a lot of reasons that they could be beneficial to someone who has a risk of abuse or has a history of abuse or has a family history of abuse or lives in a place or has individuals who might sell or misuse their stimulant medication, then using a non-stimulant may be beneficial. And it doesn't have some of the more common side effects like appetite suppression and the sleep disturbances that can happen. And you'll sometimes see these medications used in combination with the stimulant medication. So it's not uncommon to see a stimulant like Adderall or methylphenidate used in combination with something like guanfacine or clonidine because they're going to be working differently, but kind of similarly in different ways and different mechanisms. So these, the first ones I'll talk about will be the selective norepinephrine reuptake inhibitors. These are the NRIs, different kind of similar mechanism as things that you talk about like the SSRIs, the selective serotonin reuptake inhibitors, but just a different neurotransmitter. And so these are going to help with inattentiveness, impulsivity, and these are going to be atomoxetine and viloxazine. So those are going to be once a day medications that are the ones that are currently on the market. And then clonidine and guanfacine, these are ones that you've probably heard of for blood pressure as well. So that's going to be the major side effect of these. It can reduce blood pressure. So watching out for that. But it can be used multiple times a day and can help with that aggressive behavior or help with sleep too. Actually, the extended release are the only ones that are FDA approved for ADHD, but the immediate release are used because insurance doesn't love to cover a lot of these medications. So we're kind of using what we can based on insurance preferences with these medications. So drug shortages, there's an increase in demand. So we saw a lot of online psychiatry or online prescribing of these during the pandemic. And then the DEA actually sets a quota for the amount of controlled substances that a manufacturer can make. So they're setting a limit to the number of, let's say, amphetamine tablets that Teva, a drug manufacturer, can make. And so they're not able to make more than that to make up for the demand that is occurring. So that's just causing just this struggle where there's an increased demand and less supply. This link here gives you an update of all the current drug shortages, and those are the ones that most recently were on the list. We are definitely seeing an issue with the Adderall extended release and with the Vyvanse, as I mentioned. And so we, as a practice, help navigate this by changing the dosage, calling multiple pharmacies. That's typically what we tell families to do. Call the pharmacies closest to you and see what they have in stock. If they have the generic in stock versus the brand name, we can switch it to that and work with insurance to get that covered. But it can be very challenging to navigate these shortages. And so finally, just to wrap things up, ways to support students with ADHD. I was just in a talk about, as an educator, how we can support these individuals in the classroom. And so it's just having a gentle understanding and acceptance, providing routine for these individuals. They really need that routine. So preparing them if they're going to have someone different administering their medication or they're going to see someone different during the day, preparing them for that, providing that positive encouragement. So we use a lot of token reward with the behavioral therapy with ADHD, so using that as well. Having a non-distractive, non-loud environment, which can lead to some of the symptoms, communicating, but very gently and to their level as well. And then advocating both for yourself and what your role is and what you do for these students, but also for these students as well. They are Um, all of our individuals with neurodevelopmental disorders have very unique skills and are maybe hyper focused on something very unique, but they know things, they have the ability, and so it's just us working with them and empowering them to use those skills and making sure that they have IEP 504 plans set up so that we can get them the most enriching and appropriate environment for their education. And then providing a stigma-free environment and interactions with the individual themselves, with their family members. And so some things that I talk about with students with this is talking openly about mental health disorders, talking openly about ADHD, educating people on it, the commonality of it, how many high functioning individuals are out there who live with this and are able to achieve their goals and have high functioning careers, and families and friends and everything. Be very cognizant of the words that we use. So, and using first person language. So an individual with ADHD, not that ADHD or, I don't know what people are saying now, but being very specific about it's a child with ADHD, instead of I can't even come up. I'm so used to using the appropriate term that I don't even know what is said, but like what I don't say an alcoholic, it's an individual with an alcohol use disorder. So something similar to that. And then maintaining privacy. And so make I Bob Kuhn, who usually does this presentation, was telling me back in his day, people would, get on the intercom and be like, Bobby Joe, it's time for your medication, and keeping it very private and having that privacy for them. And then cultural competence. So understanding what it is culturally for both the family, for the individual themselves as to what kind of care that they want, how they expect care, and maybe how they don't want to have interactions with medical providers because of the history of misuse and misunderstanding, unfortunately. I saw the sheet. I know that you all have your own forms that you use for documenting medications, but some of these are questions that you can ask the student, like, did you eat? Have you been able to focus this week? Same, more or less. So these are available, and I put additional resources here too that can help with both like sheets, handouts, things that you can provide to families or caregivers as well. Right. Think I went over everything, so I want to just leave room for questions that you all might have. Yeah. Oh, I think I saw yours first. Oh, yes. So I have some additional slides. So the question is about gene site testing. So it's not commonly done, both for reasons that it's expensive, it's typically not covered by insurance, and it oftentimes doesn't tell us still what medication is going to work for the individual. So gene site testing is going to get a blood sample, and it's going to really just show you what enzymes you have in your liver or in your body that will alter metabolism of drugs. So it might tell you that they are a slow metabolizer of a medication, so they have an increased risk of side effects, or that they're a fast metabolizer of medication, so you might need a higher dose of the medication to get the same effect, but it's still not going to tell us this medication is going to work for you. But if someone's having a lot of treatment failures or really bizarre, unexplained side effects, then we might do gene site testing, both for ADHD, but also general psychiatry as well, like antidepressants, antipsychotics, that sort of thing. I think I saw another question. Yeah, so the question being, if an individual is on a stimulant and a non-stimulant medication, are they given at the same time? It just depends, but generally they are. If it's a morning medication, usually they're going to be taking all of those in the morning at the same time. And then the non-stimulant would be generally like clonidine or guanfacine, or primarily given at bedtime because they can be sedating. So then they would be given by themselves at that time. You should not be on a atomoxetine, Strattera, and a stimulant medication. That's very uncommon. And so that's a time that they probably need to be consulted with a specialist to get their medication streamlined. Any other questions? All right. Well, thank you all for allowing me to come talk to you all.